Hi, good afternoon, everyone. I'm Kalyan Seelam. I'm one of the consultants working in the memory clinic in Canberra Hospital. Just makes me feel a bit nervous seeing so many GPs. And I've tried to tailor my talk to the needs of the GPs, and Sabi has been quite helpful. If there's anything that you want me to repeat, anything you want to address or clarify, please do let me know. I'll take the questions as we go along. Just a couple of observations that I've made from the previous talks. Is it okay just to correct some of the things that were mentioned about Arnold in terms of medications? He was on citalopram 30 milligrams once daily. Generally, we don't stop the antidepressant medication straight away, so if there was a decision made to knock it off, try and reduce that by 10 milligrams. And again, he was on a PPI as well, which inhibits the cytochrome P450 metabolism, so it actually increases the levels of citalopram in the body. And one of the problems with that is prolonged QT interval and the sudden death. It's always useful to have an ECG. If you've got patients, elderly patients who are on high doses of citalopram, 20 milligrams and above. The other quiz question about whether forgot the question now. The anticholinergics and the other one, which increases the risk of dementia. Sorry? Benzodiazepines, yeah. Yeah, they both increase the risk of cognitive impairment, but they don't increase the risk of Alzheimer's disease, though. Alzheimer's disease, it's a disease of the brain which results in accumulation of plaques and tangles. If there is any one proven risk factor which increases the risk of Alzheimer's disease, it's age. The older you are, the greater the risk. But they do increase the risk of cognitive impairment. Sorry, I'll just do the job that I've been given now. Right. What we're going to do is use Mary as a patient and then follow the journey, Mary's journey. She's living in her own home, and then eventually, as she gets diagnosed with dementia, as dementia progresses, she moves on to the care home. And in the primary care, what are the problems that you're likely to see in the journey for Mary? So that's how I try to sort of organize my talk. So we'll be talking about if Mary visits you in the clinic, what are the pointers that you'd be looking for effective screening for dementia? And how do you actually make a decision whether the patient requires a referral to the secondary care services, i.e. the memory team? I don't know if you're aware, there's been a change in the NICE guidance in 2016, September 2016. Previously, the diagnosis was to be made by specialists, i.e. psychogeriatricians, geriatricians, neurologists, but it's been extended to primary care, advanced nurse practitioners. So GPs can make dementia diagnosis. They can initiate treatment for people with dementia. So we're going to talk a little bit about what tools are out there for you to make diagnosis of dementia and commence treatment. It's mainly for fairly straightforward patients who have got quite severe cognitive impairment, like for example, patients living in care homes, etc. There's been a change in the service specification for the memory services. I'm not sure how many of you are aware of that. We'll have a polling later on. I'm going to talk a little bit about what is the change, what is the new service specification for the memory services in Barnsley. In fact, we have changed the name. The CCG wants us to call ourselves Memory Assessment and Support Service, MASS. We're going to talk a little bit about that. And again, shared care, this comes up quite a few times in interactions with the GPs. There's going to be a slight change in the shared care as well. A lot of the patients who are stable on cognitive enhancers, they probably will be discharged back to primary care. So how can we help you with that? What are the things that you would be looking at when you do reviews in your clinics for these patients? And how can you gain rapid access back into memory services if there is a problem? If there is any change, if there isn't anything that has changed in the talk, I've delivered the talk in 2012. It's going to be on the cognitive enhancers because the evidence base has not actually moved so much, and that probably reflects the pace with which the research in dementia is progressing. We are still stuck with the 4 drugs, 3 cholinesterase inhibitors and memantine. I'll briefly talk about some of the studies that have been done in the last few years, which basically add more evidence to the use of these medications. Capacity assessment, it's a huge topic, and it does vary from what the key issue is. So the relevant information that you actually give to the patient depends on what the decision is. It's decision specific and time specific. But we'll see if we could cover some of the two common scenarios that you might face in primary care. BPSDs, behavioral and psychological symptoms of dementia. How do you deal with those? The use of antipsychotic medications. Dr. Om has actually talked a little bit about that in the previous talk. Right, let me start off with this question. If you can use your little gadgets you've got, are you aware of the new service specifications for memory assessment and support service? Okay. Oh, wow. Andy, we're not doing a good job. Right. What we have is a hub and spoke model. I'm going to briefly mention about the model that we have. The memory assessment and support service is based in Kenbury Hospital, but we outreach into primary care, the care homes. We jointly work with third sector, and we work with the acute hospitals as well as the Mount Vernon Hospital. I suppose the most important bit in this talk would be what the interaction is between the memory service hub and the primary care. I'll try and elaborate that in the next few slides. Each GP surgery should have been assigned a trio of memory workers. The two of them are nurses. One of them is a senior nurse at a band 6 level. The other one is at a band 5. And then a support worker at a band 3. The support worker is also called as a dementia advisor. So you should have a trio attached to each GP surgery. And what do? They actually help in effective screening of referrals. So if you're stuck, Mary comes to see you, you're not sure as to whether Mary would require a referral to the memory services, you could liaise with the trio and request for some help or advice. So it's pre-diagnostic and advice support. And that also extends to assessment and diagnosis. So the assessments are carried out within the primary care or in the patient's own homes. The CCG is really keen for the integration between the memory assessment and support service and the primary care. Once a diagnosis is made, they help them with treatment and management, helping them live well with dementia. And as the dementia progresses, if they were to go into care home, they perform the care home liaison function as well. So essentially, you have the same three people who follow the patient from the start of the journey till the end. And if there is a need for involvement of palliative care, again, these trio will get in touch with the appropriate people, professionals in primary care, and help support them die well as well. So that's the model that we would be looking at. The service specification has gone, in fact, we piloted this in from January 2015 until June 2016. There was an evaluation, and following that, the CCGs agreed that this model fits Barnsley. It meets the needs of Barnsley patients. Because the next question is, do you know who your dementia advisor / the trio is? Wow. Right. When you get your certificates, you will also get the pictures with the names and contact details of the dementia trio. We have actually sent a lot of these information to the practice managers a few weeks ago. So if they have been printed off, you should find them in one of the notice boards in your surgery. But what we're hoping to do is over the next few weeks, myself and my colleague Andrew Stones, who's a nurse consultant, we'd be going around the GP surgeries, introducing the trio members, and hopefully attend the practice meetings for a few minutes just to talk about the role of the trio. Right. What we have done is we have divided all the GP surgeries into 6 clusters. So each cluster would have about 6 or 7 GP surgeries. And that cluster is allocated the trio. Our vision is to actually align the trios who are working with these GP clusters with the neighborhood teams. This is the community nursing team. So hopefully, whatever the problem is for the elderly person in Barnsley, it can be a one-stop shop. So you've got the dementia service working closely with the primary care, working closely with the neighborhood teams. That's the vision. Hopefully, over the next coming months, we should make it a reality. Oh, really sorry. I'm not doing well. Right. What is the service offer? What do we do? The Barnsley Memory Assessment and Support Service is a dementia hub. This is probably, in some ways, a bit unique from other services in the sense that we actually perform a lot of functions that various other teams do in other places. Like, for example, you may have a separate memory clinic for the assessment and diagnostic service, a separate team for the care home liaison team, a separate team for the crisis team. But we have all of these under one single roof. So we do the assessment and diagnosis. We perform the CMHT role, community mental health team. So we support the patients once the diagnosis is made with titration and management, helping them live well with dementia by working very closely with the third sector. We also operate like a crisis team between the hours of 8 a.m. and 8 p.m. It used to be 8 a.m. to 6 p.m., but is it last week that we have? Yeah, from this week it'll be operating from 8 a.m. to 8 p.m. Monday to Friday, and we also have plans to actually extend that to weekends, Saturdays and Sundays. We also perform the functions of hospital liaison team. There's a dedicated hospital liaison nurse who's a link with the hospital, both the hospitals, Mount Vernon as well as the Barnsley District General Hospital. And we're also a care home liaison service. So essentially, all these functions are carried out by the trio who follow the journey of the patient. And we work very closely with the primary care, social services, the third sector, Alzheimer's Society, and BIADS who are here today. Very quickly about the dementia pathway. So what happens when a patient is referred to our service? We receive referrals from the GPs, district general hospitals, and other healthcare professionals. If there is any doubt about whether the patient is to be referred to the memory services, you could run it by the Band 6 nurse, who is a member of the trio that is attached to a GP surgery. Some of the surgeries have really adopted and embraced this model, and they have actually set up screening clinics for the Band 6 nurses, and they seem to be working really well. You've seen a patient, you're not clear as to whether the patient would require a referral, you can just set up a screening clinic for a nurse who comes and visits your surgery once or twice a week, and they actually screen them. If they are appropriate, then they actually follow the patient, carry out the initial assessment. If they're not appropriate, then they may signpost as to what is the most appropriate service for them. And in screening, we generally look for the demographic details, contact details with the family, any medical psychiatric history. That's what helps us to effectively screen out the patients that are not appropriate for us. Then an initial assessment is carried out by the nurses in the patient's own home. It's usually a very comprehensive assessment, takes about 2 hours, looking at the history, cognitive assessment, carer stress, other issues like depression, falls. And if the patient's presentation is very typical of a dementia, and if a diagnosis can be made within the MDT meeting, they actually bring it for the multi-professionals diagnostic forum, which is attended by all the professionals, including psychology, OT. A diagnosis is made, the patients then commenced on medications. Then they are passed on to the trio members to actually titrate them on the cognitive enhancers and signpost them to appropriate support services in Barnsley. I suppose the bits that are most relevant for the primary care is screening, effective screening, and once the diagnosis is made, the patient's passed on back to yourselves for the shared care to prescribe the medications and to monitor their presentation. So a lot of the things actually happen in the primary care. in the initial stages of the dementia, what we are involved is mainly with the diagnostic process. Right. I'm going to talk a little bit about what are the pointers that might help you in effectively screening a referral when the patient sees you in the clinic. You've got about 7 or 10 minutes. How best you can use this time to screen the referral. So we just go back to Mary. She's a 72-year-old Caucasian female widow. Well, effectively, she's not a widow. She was a widow when I sent this presentation, but later told she's got married to Adnol, so husband's in a care home. Yeah. Let's assume she's married. Yeah, she's living on her own, and she has a 6-month history of memory problems. Her daughter is more concerned about her memory problems, and she's the one who's actually instigated the referral to see the GP. Mary herself does not acknowledge she has any problems and attributes the minor memory deficits to her age. It's a very common scenario. I'm sure it resonates with a lot of your patients. In terms of medical history, she's got atrial fibrillation, hypertension, and depression, problems with insomnia and overactive bladder. She's on aspirin, oxybutynin, sertraline, and amitriptyline. Yeah. Possibly, yeah. Right. So this patient has come to see you in the surgery. Can you just shout out as to what are the things that you're looking at in the history which would enable you to think along the lines of whether this patient has a cognitive impairment, and if so, is it because of an organic condition, which then would mean that she would require a referral to the memory services? Maybe got about a minute or so. If you just shout out, in terms of history, what is it that you're looking for? Absolutely, yeah. Yeah, 6, yeah. Absolutely, yeah. Yeah, progression, yeah. Right, okay. Just move on. In terms of history, it's always important to look at the different perspectives. The patients usually come with their loved ones, daughters, sons. So it's important to know who has actually instigated the referral. Is it the patient or the patient's family? Patients' families, they're the ones who normally are more worried about the memory problems. Generally, they tend to have the neurodegenerative illnesses. Worried well, they're the ones who tend to come along themselves requesting for a referral to the memory services. So that simple distinction can actually help you understand whether the patient is likely to have a neurodegenerative illness. Onset, duration, and progression. A couple of minutes just exploring as to when did they start, how the progression is. There's a notion that if the cognitive impairment started suddenly, then it's more likely to be due to a vascular cause. From my experience, what I've noticed is the patients may be functioning okay in their own home environment, but the functions get decompensated when they are in a completely strange environment, when they go on holidays. And sometimes the carers tell you that this patient's problems have started quite suddenly when they were on holiday, but they may have been having problems with the memory for quite some time. So it's worth asking, is it truly sudden in origin? Some minor deficits could have been attributed to normal aging process. It's worth asking, have you noticed any subtle changes in a mum's presentation, memory, functioning, etc.? And then you will unpick quite a few things. Some of these may have not been attributed to any disease as such. They would have thought it's normal aging process. Fluctuations. Usually, dementia with Lewy bodies is one of those conditions which presents with very marked fluctuations, and these can last for sometimes a few minutes, a few hours, and a few days. The fluctuations are so marked that you wouldn't believe seeing the same person a few days later when the patient is having a very severe presenting with severe cognitive impairment. So it's worth asking for any fluctuations. If patients come up with a history saying, I've been having problems for the last 10 years, I've been getting more forgetful, generally it doesn't fit in with a neurodegenerative illness. It tends to be more of anxiety or worried well. If they're present with a very short history, a few months history, a few weeks history, there's usually a treatable cause of dementia, especially for youngish patients. It's worth just looking at the medical history once again, looking for any neurological problems, looking at the bloods. If you see an elderly person assessing problems with general physical functions, you do staging. Generally, we ask them as to, for example, problems with mobility. When did you start using one stick? When did you start using two sticks? When did you start using Zimmer frame or wheelchair? Likewise, you could actually do a bit of staging for dementia as well. You could ask them, when did you stop going out? When did you stop shopping yourself? When have your loved ones taken over managing your finances, opening your mail, looking at appointments, organizing diaries for you? One of the most, from my experience, if you hear a history that the spouses have actually gradually taken over the chores, it's definitely a very strong positive discriminatory symptom of a neurodegenerative illness. They've noticed a gradual decline and slowly they take over the chores that are performed by their loved ones. So you've got about 4 tasks really to perform in about 7 or 10 minutes time that you have. Task 1, does the patient have an organic cognitive problem? Task 2, is the disease process static? Is it progressive? Is it fluctuating? Is it vascular in origin? Task 3, what are the cognitive domains involved? And task 4, is the patient depressed or is anything else going on in the history? Suppose the most important ones are task 1, 2, and 4. Task 3, leave it to us. We will carry out as to more cognitive assessments to establish what are the domains involved, which then would enable us to arrive at the diagnosis. So in terms of effective screening, maximizing the information in the 7 or 10 minutes time that you have, look for any implicit sources of information. As the patient is walking, look for any gait apraxia. Says walking as if they feel the feet are stuck to the ground and they have freezing episodes, they have difficulties in turning around. If you notice that, it's usually indicative of a subcortical vascular problem. Normal pressure hydrocephalus can also cause that. Is there any evidence of sensory impairment? It's one of the things that's most often missed. Deafness, loss of vision, these can exacerbate the cognitive impairment. Simply doing an ear syringe, helping them with hearing aids, some aids and adaptations, it can improve their cognitive functioning. When you ask the patients to sit down, can they easily find the chair, and how do they actually sit? I call it a bum apraxia, but it's not a medical term as such, but they cannot place the bum exactly in the center of the chair. You can clearly notice that if they have come with a carer, the carer usually goes behind the chair to place it exactly in the center. That probably would indicate some sort of a visuospatial functions. Who plays the primary role in the consultation? They call this a head-turning sign. You ask the patient, what brings you here? And the next thing you notice is you look at the family members to prompt for information. Several studies have been done looking at head-turning sign and correlating with perfusion deficits in the brain scan. It's again a very strong positive discriminatory symptom. What is the quality of interaction in the consultation? Who is actually taking the lead? Most patients with dementia, they're not aware of what is happening around them if they have the moderate degree of cognitive impairment. So they're not interested in the conversation. They sit very quietly, and most of the conversation is led by the carer or the family member who accompanies them. Any evidence of shakes in the hands, any eye movements, might give you some information about other neurological conditions that may be associated with cognitive impairment. So if we unpick these 3 tasks that you have, is there an organic problem? Look for any anecdotes of the patient's complaints. Ask them, can you give me some examples of what brings you here? Why do you think you've got a problem with your memory? Some of the three questions that I normally use is, what is the worst thing that has happened because your memory has let you down? How has life changed? And how does your poor memory stop you from doing what you're doing? And they actually come up with either the family member or the patients. They give you a good narrative of the problems that they've been having. It's important to attribute some weightage to the patient's complaints. So I've sort of divided them into poor discriminators and strong discriminators. Suppose one of the key things is, if somebody complains of memory problems and gives you an anecdote, it's worth thinking, can I do that? Can my parents do that? Is this normal? Some of the poor discriminators are going shopping and forgetting items. We do that quite often, losing items at home, going into room and forgetting why, forgetting appointments, not passing on messages, losing the car in the multi-story car park, having to be told more than once.
Callius, can I say, when I was going through the slides to put them on, I didn't see that top title to begin with, and I just looked at all of them and I just thought, oh my God. And then I thought, then I looked at the title. I thought,
these are all very poor discriminators. These could happen with normal people. Basically, these are attentional lapses. So what is it? What are the complaints that you're basically looking for? So these are the good discriminators. Asking the same question repeatedly. So it's perseveration of speech, going about, I think if you spend 10 minutes with a patient who's got real cognitive impairment, you will clearly notice this. They will say the same things over and over again. Participates in a conversation and then forgets that this has never occurred. Despite prompting, they would have difficulties in recalling that information. Normal aging process and the cognitive impairment associated with that prompting helps them to recall. So it's predominantly the retrieval deficits that you would see in people with normal aging-related cognitive impairment. But if they have difficulties recalling despite prompting, it would definitely indicate an organic pathology. Taking the spouse for shopping with them and comes back alone, goes to town by car and comes back by bus, gets lost every time in unfamiliar places. In fact, this can be the very initial symptom that patients present with, especially when they are in unfamiliar surroundings, in holidays, when they're on holidays, etc. There's a condition called semantic dementia, where people lose the ability to recognize objects because they've lost the meaning of the object. They have difficulties in understanding the meaning of the word. An example is couple went for a dinner and the spouse, Arnold says, we wanted to have fish for dinner, and Mary says, what is fish? She lost the meaning of the word fish. They can present with such similar symptoms as a presenting complaint. Semantic dementia presents predominantly with loss of meaning of words, loss of meaning of objects. The memory problems, it's not a major issue. They can't remember things well. If I'm seeing patients maybe just after Christmas, I always ask them, how was Christmas? And people presenting with significant cognitive difficulties, the answer that you get is it was chaos. She's been buying gifts, same gifts over and over again for the same person, and she's been writing cards for dead people that she's forgotten that they have been dead. And Christmas is usually a time which requires a lot of executive functioning, a lot of planning, organization, and when the brain gets decompensated, they have lots of difficulties in dealing with that. So that could be a very positive discriminatory symptom. And sometimes you do hear family members complaining she can't find a pencil when it's right in front of her. And there's no problem with her eyes. She's been taken to an optician and they have checked over and everything's fine. So it's again a condition called as posterior cortical atrophy, where the disease starts in the parietal and the occipital lobes. But the memory is absolutely fine, but they have difficulties in processing of visual information. So they have difficulties in seeing things that they have got in front of them. Task 1 again, pointers to organic disease. Point one, who is more concerned? Is it the patient or the family member? Who actually dominates the interview? Who actually triggers the referral? Look for loss of functioning and the chores gradually being taken over by the spouses. Episodes of marked disorientation in new environments. If you've got any of these 4 pointers, it's most likely to be a condition due to organic problem. Task 2 is, what is the nature of dementia? I don't want to go through various pointers, but there is, if you use age as a discriminatory factor, that is good enough. I think in 10 minutes of time that you have, if you just stick to the age as a discriminator, it might help you to screen out the referrals. Patients under 40 years, dementias are extremely rare. It's less than 1%. Most of them tend to have some sort of a psychiatric condition, depression, anxiety, or they could just be worried well. And sometimes people do have certain neurological conditions, multiple sclerosis. I quite often see people with fibromyalgia or ME, sometimes SLE. You may have heard of the term fibrofog. They have difficulties with attention, concentration, and they have difficulties with memory problems. They don't have a neurological condition. It's the predominant problems with attention and concentration which makes them more amnestic. If the patients are between 40 and 55 years of age, again, a bulk of this group who fall in this age group who present to the memory services do have some neurological conditions or psychiatric conditions. They could be worried well. But you may see some neurodegenerative diseases like frontotemporal dementias. It's usually the age of onset between 40 and 55 years. And secondary dementias are quite common, secondary to many other medical health problems, hypothyroidism, anemia, treatable causes. It's worth just going through them. Patients whose ages range between 55 and 65 years, and this is where the organic conditions are becoming much more common. And this is a typical age for somebody to present with a frontotemporal dementia. The language variant that I mentioned about semantic dementia, where they have the difficulties in understanding the meaning of the words, that age group, it actually falls in this age group. You may also see patients who have got a very strong family history of Alzheimer's dementia. So familial Alzheimer's dementia, the typical age of onset is between 55 and 65 years of age. Patients over 65, most of them will have an organic cause. So definitely if somebody is above 65 presenting with cognitive impairment, they probably would need some sort of an assessment by the memory services. Which cognitive domains are involved? We do that, and we carry out a cognitive assessment and then carry out various sets of investigations to establish how severe the cognitive impairment is, which then leads to the diagnosis. Task 4, I think this is something which is quite often missed and which can be quite difficult as well. Is the patient depressed, and is there anything else that's going on? Depression in elderly people can present with significant cognitive deficits, and you probably may have heard the terms depressive pseudo-dementia. So they have difficulties in engaging with the tasks. They have difficulties with attention and concentration, which manifests as amnestic symptoms. So maybe we're just trialing a small dose of antidepressant medications, ask them to come back again in about 3 months, see if that improves the depression, and if it has it improved the cognitive impairment? If not, then it's worth referring the patient to our service. Other medical conditions, vascular risk factors, head injuries, seizures. If there is any history, then it's worth looking if these could be causing the cognitive impairment. Drug history, rule of thumb, any drug that causes the blood-brain barrier, which acts centrally, can have an impact on the cognitive functioning. I think you must have, Dr. Ohm sort of mentioned about the various medications which increase the anticholinergic activity in the brain. So cholinergic activity, anticholinergic burden is important in establishing whether this could be causing the cognitive impairment. If they've got any family history, clearly they would need a further assessment. And alcohol is again quite often missed. As a general rule of thumb, for a man, if they have been drinking more than 50 units for the last 5 years, they're at a very high risk of developing alcohol-related brain damage. For females, if they're drinking more than 35 units per week for the last 5 years, again, very high risk of developing alcohol-related brain damage. If they're drinking excessively at the point when you've seen them, we may not be able to get an accurate picture in terms of cognitive assessment. So it's worth referring to alcohol services, looking at other alternative approaches to help them cut down the alcohol intake. Right. Just going back to Mary. So you've seen Mary in the clinic. Which of these could potentially have an impact on Mary's memory problems? Yeah, that's right. Yeah, that's right. Yeah, excellent. Amitriptyline does have quite significant anticholinergic properties even in small doses. So it may be worth changing it to something else. Most of the time it's prescribed for insomnia. Oxybutynin, we have talked about that. And depression, again, it's worth treating the depression first and see if that improves the cognitive functioning. So what else have you got in your 10 minutes of time? Can you use anything in terms of cognitive screening tools? The most commonly used is 6CIT. It's a 28-item scale. The higher the score, the greater the impairment. I think it's available in the BEST website. Yeah, okay. Yeah. Lots of other tools, if anybody's interested, to look into them. There's one called as confusion assessment method, and this might be relevant for you when you're reviewing patients in care homes or presenting with very severe cognitive impairment, or where there's a sudden onset of change in the behaviors to rule out any delirium. Oh, I've done that again. I should stick a tape on this now. Yeah. The next one is in fact, the confusion assessment method. Basically, it's looking for any fluctuating cause, acute onset, any problems with inattention. In fact, this is one of the pathognomic features that you would find in delirium. They would have lots of difficulties in sticking to the conversation. Thought process is quite severely impaired. Disorganized thinking and altered level of consciousness. IQ code, it's an informant questionnaire. You could give this to the receptionists, and while they're waiting outside, the family members could fill this in. It's basically asking how have they changed in terms of their functioning. All you have to look at is how many ticks they've got in these last two columns, column 4 and column 5, and that would indicate that there's been a significant decline in their functioning. So some of the tips in terms of screening the referral effectively, if you think the patient would require a further assessment by the memory services, please discuss the referral with the patients. And sometimes we do see patients, they're not aware that the referral is being made, and when we contact them, they basically give us an earful, which can be quite difficult to manage. Please mention about the brief history, medical history, any ongoing specialist reviews, medications, allergies, any recent investigations, especially any neurological investigations. It's really helpful for us. We can liaise with them and see what they're doing. It avoids duplication of work. Any other possible thoughts on the causes of cognitive impairment? I think Sabi has actually put in a referral form on the BEST website.
Apparently apparently we're not allowed to use it from the website. However, with Dr. Seelam, we've made an electronic version of the dementia referral form, and it's in EMIS and it should be on System 1. And Dr. Garni earlier today said we have to fill it in now before we refer patients to yourself.
It's fairly simple. In fact, a lot of things that you've been doing, it makes things a lot easier for you. A lot of it is actually pulled through from the information that you already have.
If you look at, say, the majority of the stuff, it's going to be self-populated, but the question Dr. Seelam was asking that they would help them more, those are the ones that they want us to answer, but I've done it as a tick box, so it's not, you're not having to write anything extra. Have a look, see what you think. If you think anything needs to be changed. Have a look at the form. If you're unhappy, then we'll make the change.
Yeah, sure. I don't think it's the form is any. It's not. Yeah. They need a referral as well, isn't it? You just yeah. They need some information about as to why the patient is being referred to them, what the key issues are in terms of screening the referral. I don't think the referral form is actually onerous. It takes a couple of minutes, I think. Most of it is self-populated, basically. It pulls out the data from the information that you already have, medical history, medications, allergies. Yeah.
This is the kind of stuff that they wanted to know.
You'd have to basically tick the boxes, whether it's 12 month or less than 12 month duration. If it is less than 12 months, it would be helpful for us to know for how long has the patient been having these problems. Most of the times, for complex patients, even when the referral is screened by the Band 6 nurses, if this referral was to come to the hub, one of the doctors would probably be seeing the patients. So we would need some information about we don't have access to the EMIS, System 1 in primary care. So at least the basic information about the patient's medical history, medications, allergies, it would be helpful for us to have. If you think the form is really troublesome in filling or... Yeah.
We put the referral letter in EMIS. She has access to the patient's records, so all of that information, and it's got kind of word-for-word quotes from what patients and relatives have said.
Yeah.
Obviously, if we're doing that already, we're not then going to go and open a form up, tick all of that, print it off, put it in a tray for her to look at, when actually she's already got access to that, can see all of the relevant medical information. Or are we just going to print a form, put nothing in the notes, none of that stuff that actually helps, and we're just going to give her this saying it's been more than 12 months, crack on. I think that's the issue, that we're already, if that information is already there, why are we doing it twice and not twice?
In fact, the information that you've actually put in the system is actually pulled through into these referral forms, so it's not actually a duplication of work.
That's already
the practice does vary from GP surgery to GP surgery. So I think if you think that is working for you, you can always look at making things better. If there is anything that you want us to take off from the form, or we probably would have to...
I guess it's like our 2-week wait forms. Because we've got to tick everything, we make sure we do it before it goes. And because of the variation in practice amongst all of Barnsley, so that all the patients that are being referred, I guess, appropriately. And it is literally just tick, 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 tick. But do you know that the long, detailed consultation with the memory problem? You don't have to write any of that. That will just all go in, but with the extra.
You see a lot of unhappy faces. I've shot myself in the foot here. So, yeah, go on. Sorry?
Dementia and driving.
Yeah.
I had a problem recently. The patient was not ready to accept that he has got the dementia enough to stop it.
We'll talk about that later, probably, yeah?
We'll come to
the rest
that.
of the talk.
That's fine, yeah. So I'll quickly skim through the referral form. We don't have the choose and book function at this point in time. I think we have been receiving paper referrals. There is an option. We've been thinking about whether this referral form could be sent electronically if there is an email, secure email ID, nhs.net account. Could actually send it to that. That's one other thought we have. It actually speeds up the process. We don't have a choose and book option. I don't know how it works with choose and book. Or an email. Yeah. So what do we share with you once we have done the assessment? You get a diagnosis and formulation. We provide the diagnosis with the GP read code, and we're trying to do the EMIS as well as System 1 codes in that. I think you have got a QOF requirement that you maintain a register for the dementia patients. And there's some confusion about whether you would include a possible or probable dementia in the QOF register. So there's some guidance given by the Yorkshire and Humber Strategic Clinical Network. I don't want to go through all of that. It should be in your pack, yeah. So this is all what you get, what the cognitive enhancers are, what support systems the patient would become eligible for, psychoeducation, post-diagnostic support. We do the cognitive enhancer titration, stabilization, and monitoring, and then we will send request for a shared care if the patient's been on these medications for at least 3 months. So this is the template that we have designed. If there are any abnormalities in the bloods that we would want you to cast your eyes on, it's probably here, and we would try and make it very clear in the management plan in bold letters. A bit about the diagnosis of dementia in primary care. Previously, the guidance was that secondary care medical specialists like psychiatrists, geriatricians, and neurologists, these are the only ones who are allowed to make a diagnosis and commence treatment. But it's changed in 2016. So GPs, nurse consultants, advanced nurse practitioners with specialist expertise in diagnosing and treating Alzheimer's disease, they can do that as well. There is a tool that's been developed. It's called Diadem. It should be in your packs. Basically focuses on 5 parameters: functional impairment, cognitive impairment using 6-SIT, then collateral information from the family members. Can't read that. Any investigations and any exclusion criteria. So it should help you in making the diagnosis, and mainly for patients who are quite severely impaired living in care homes. Now, let's say Mary has come through our service. She's been diagnosed with Alzheimer's dementia, and she's been titrated on the donepezil 10 milligrams a day. She's been stable on this medication for 3 months, and a shared care has now been requested. So when do you request a shared care? The patient meets the clinical criteria within the NICE guidance for the use of cholinesterase inhibitors and memantine. What we do is at 3 months, we do a review of these patients and make sure that the patients are benefiting from these, and the patient's dose is stabilized. It usually takes about 3 months, sometimes a bit longer. If there are any ongoing side effects with the patient's not stabilized, then we won't request a shared care. There isn't any special monitoring required for these medications. I think these have been in practice for at least 2 decades now. So there's a lot of evidence around the use of these medications and monitoring by primary care. So what we have suggested is that these patients will get a review after 6 months by the memory service, and if everything is fine, they will be discharged back to the primary care. Because they don't require any special monitoring as such, the reviews can be tied in along with the annual reviews that you would have to do. Again, a QOF requirement for dementia. If there are any concerns identified at this point in time, and these patients would require input from the memory services, these patients could be referred back to the memory services. We have given assurance to the CCG that any such patients who are referred back to the memory services will be reassessed within 48 hours of being referred back to our service. So we have set up some rapid access clinics. If there's any problem, you can always refer back these patients to us.
Because of time, probably better if we leave out all the website.
Yeah, we just.
To show where the shared care guidelines for the dementia drugs are on the website. So it's under medicine information, shared care guideline. Next slide. Yeah, Alzheimer's. Next slide. Yeah, just press on that. It's all there. Everything, who to contact.
Yeah.
Skip
I'm going to try and skip this. Basically, what these drugs do is the 3 cholinesterase inhibitors, they increase the levels of acetylcholine in the body. We talked about anticholinergics earlier on. They block the acetylcholine, and hence they increase the cognitive impairment, whereas these drugs do completely the opposite. They increase the levels of acetylcholine. Memantine, it works slightly differently. It basically reduces the cell death by controlling the noise or the increased signaling, which is one of the hypotheses to explain excessive cell death in people with Alzheimer's. Just don't want to go through the whole evidence. There's very good evidence for the use of cholinesterase inhibitors and memantine. The new guidelines, the BAP guidelines, British Association of Psychopharmacology, have actually looked at some of the recent studies, and they do show that people who are on cognitive enhancers, it actually delays the placement in 24-hour care by about 18 months to 2 years. So there is a strong reason why we should be prescribing these medications. It improves the quality of life, preserves the quality of life for that period. Some of the side effects from these medications, these cause bradycardia, so that's one of the more significant concerns. If somebody's got bradyarrhythmia, sick sinus syndrome, we'd have to be extremely cautious. The number needed to harm is 7. Last time when I did the talk, somebody asked me what is the number needed to treat. I didn't have an answer at the time. It's 6. Number needed to treat with cholinesterase inhibitors is 6 for stabilization. It's about 12 for patients who show some mild improvement, and 42 for patients who show significant improvement. Memantine doesn't have any of these cardiovascular side effects. It's much safer. I've already talked about this. Once the patient is stable after the 6-monthly review, they will be discharged back to primary care. Yeah. So Mary comes back to annual health reviews. She's been stable on cognitive enhancers, and the feedback suggests that there's been a significant decline, and the family members request if the medications are actually benefiting Mary. Can we look at stopping the medications? So when do you discontinue cognitive enhancers? I think Sharat asked this question earlier on this morning. So when do you discontinue the cognitive enhancers? You may see patients on these medications in care homes. Wow, yeah. What the current guideline says, a patient himself or herself, if they've got capacity, makes a decision to stop. You can stop it when there are concerns about medication compliance, and when there is no apparent response to therapy. This is really tricky. The recent evidence from 2 big trials that were done, a domino trial that was done in 2014, suggests that when you see patients, you may get the information from the carers or the family members that they have not shown any improvement. They're in fact declining. What the evidence has shown is once you stop the medications, the decline is much faster. The decline is quite rapid. So if somebody is living at home, I would be really tempted to leave the medications as they are, even though you may not notice any apparent improvement in their cognitive functioning. Even for patients who are living in the care homes, if the quality of life is worth preserving, we're not talking about somebody who is bedridden, the care is being provided in bed, the patient requires feeding, is not able to communicate, multiple physical health problems, there may be a strong reason to discontinue. But if somebody is engaging in activities within the care home, going out with the family members, is able to communicate needs effectively, I would still keep them on. You stop the medications, you will see a rapid decline with these patients.